Welcome to AETCM, the Emergency Medicine channel.
Yeah, so I'll give out a scenario. We have an 20-day-old, very clear, 20-day-old child. Mother have found that the child is having some bluish discoloration of his lips and upper limbs since last 4 hours. So that is the reason the mother has brought the child to the emergency room.
So coming to PAT assessment, appearance of the baby is
Appearance of the child is in the mother's lap, lying now, and the child is sleeping right now.
Work of breathing.
Work of breathing looks appropriate for the age. There is no indrawing, intercostal indrawing. There is no nasal flaring or any of these things.
Color is cyan.
Color is child is cyanosed, and you are able to see some cyanosis over the lips as well as over the peripheries.
And then coming to primary assessment,
Okay.
coming airway.
So what will you make an initial impression at this point of time?
Since there is no respiratory distress associated with cyanosis, mostly it may be due to a cardiac cause.
Okay. So either we have two probability here, respiratory versus cardiac. So preliminary, there is no tachypnea involved, and being 20 days into the life, so you are suspecting primarily a cardiac pathology. So from the age group, why it is 20 days? I have given a clue that it is 20 days. So from the 20 days, what are the possible differences that you can consider of a 20-day neonate coming with cyanosis? You can tell me if at time of birth, after 1 month, what are the differentials? You can tell me.
At the time of birth, there will be the peripheral cyanosis causes maybe acrocyanosis, which is benign. It will be maybe up to till 48 hours.
Okay.
It may be due to hypothermia, any shock, any sepsis, like that causes. And then if there is central cyanosis, it may be from normal till 5 to 10 minutes of age. And then the causes may be both respiratory and cardiac. Respiratory causes may be primary due to lung tissues.
Okay. So the initial phase, during the birth itself, the child is cyanosed. So it will be more predominantly, we will be thinking in terms of
congenital
respiratory issues, mostly during the birth itself. After like 3 hours of birth, 4 hours of birth, the child is tachypnic, cyanosed. So primarily we have to think a respiratory related issue. Usually the cyanotic heart disease, they will present little bit later. So that is a one difference that you can keep in consideration. So the cyanotic heart disease, whenever the child is after 20 days, maybe within less than 1 month, they will sometime present. Maybe 1 to 6 months also they can present. I am not denying the fact. But usually the initial phase, you have to think of respiratory. So among respiratory pathologies, what are the key respiratory pathologies that you need to keep in your mind?
If there is any meconium aspiration syndrome, and then any transient tachypnea of newborn, and then any hypoplastic lung injuries, and then
what is transient tachypnea of newborn?
That is mostly when there is an after LSCS, the lung will be with fluids, and during vaginal delivery there will be the squeezing of lung and the fluids can exit. But in LSCS it is not able. So there is a transient tachypnea of newborn. It is still up to from birth to 2 hours.
2 hours, okay.
And then respiratory distress syndrome, because maybe because of surfactant deficiency, maybe due to preterm delivery or a diabetic mother, child of a diabetic mother.
Okay.
That is also like till from minutes to hours.
Okay, so we'll just go a little bit behind. So what are the risk factors that you can consider for a cyanotic child? What are the common risk factors that you have to ask in the history?
Any consanguineous marriage, any diabetes, gestational diabetes mellitus, or any gestational hypertension, any IUGR, and then any drugs.
Premature rupture of membranes. Whether after rupture of membranes, it was a prolonged delivery. So any history of any beta streptococci infection in mother. So these are the usual histories that we need to ask for, whether the child is any prone for sepsis. So premature rupture of membranes, prolonged labor, these are all indicators that the child can have an early sepsis. So that is one thing that we need to ask. Like you said, gestational diabetes mellitus, any congenital heart anomalies in the family, or whether a proper screening has been done, any hemoglobinopathies in the family. So these are the 4 differentials that you need to consider for a cyanotic child. Will be one is congenital heart disease, one is respiratory related, other is sepsis, and other one is hemoglobinopathy. So these are the 4 most important differentials that you need to keep in your mind for a cyanotic child. So what I told, when usually during birth onwards, it will be primarily a respiratory related pathologies that the child will be cyanosed, and usually congenital heart diseases, they will not be presenting that immediately, maybe a little bit later. So that is like our presentation, we have 20 days of presentation. So what all the other histories that will be very important that the mother might be able to give you for an probable congenital cyanotic heart disease? What you ask, then only the mother might be giving, because they will not be thinking that as a major concern when they are bringing the child to you.
Any history, just labor history we can ask for the child.
Anything particular to the child?
Feeding.
Feed. Whether the child is adequately taking feed. Very important. Maybe usually the feeding time will be less than 40 minutes. Usually 20 to 30 minutes the feed will be over. The child is taking a longer time to take feed because of sucking, inability to suck the breast milk properly. So that is one important history that you need to ask for. So whether there is any feeding problems, very important to ask for then.
Any fever?
Fever history, okay. Cyanotic heart disease, what? Any in between history of breathlessness, tachypnea. The child is having tachypnea or any irregular breathing. The child is suddenly having an irregular breathing pattern. So all those things you can ask for from the history in mother. That will significance more in favor of an probable congenital cyanotic heart disease. So when you are labeling as congenital cyanotic heart disease, it's a broad spectrum of disease. So what are the major congenital heart disease that the child can present with?
Cyanotic congenital heart disease mainly tricuspid atresia, tetralogy of Fallot, transposition of great arteries, and TAPVC, that is total anomalous pulmonary venous circulation.
Okay. So let's come back to the case. 20-day-old child. We have thought these are the process. So 20-day-old child, we are thinking in, as you said, from your initial impression, you are suspecting probably a congenital cyanotic heart disease. Now let's start with the primary assessment. So what all things that you want to know specifically in a child whom you are suspecting a probable congenital cyanotic heart disease. So that is the
airway will be most probably there. It will be patent.
Anything that specifically that you want to look in the airway?
Any large tongue or
foreign body, 20-day unlikely, but laryngomalacia, cyanosis presentation, stridor, yes, you have to think in terms, but cyanosis as such may be very rarely. If there is a transient hypoxia because of laryngomalacia, it can be the stridor, as you said, stridor, mostly whether it's a central or a peripheral cyanosis. That's what I was asking for. You need to look for the mucous membrane for whether it's a central or a peripheral cyanosis.
Then breathing.
Breathing, what are the key things that you want to know in breathing?
Respiratory rate, whether there is respiratory distress or not, if it is more than...
I told you the child is comfortably sleeping in the mother's lap.
Pattern of breathing.
Pattern of breathing, normal pattern of breathing. So from this, all this clue, what do you think the probably diagnosis would be? From a child, cyanosis is there, but child looks stable right now. So what could be the possible differential? Congenital cyanotic only. We are not, because the initial phase, there was no pattern that we are able to identify. Now the mother have brought in the child. So still we are in terms of a probable congenital heart disease. But instead of that, I am giving a clue that the child is quite tachypnic. 20-day, the child is quite tachypnic, breathless. So what will be the other consideration?
Then we'll have to think about respiratory.
Again, sepsis, neonatal sepsis we have to consider. So usually they can have, I am not saying that congenital cyanotic heart disease, they will be stable, but usually they will look cyanosed, but usually they will not be having that much tachypnea. So that is the differential that you need to keep in your mind. Okay, now airway, breathing.
Saturation.
Saturation. Now what all saturation specifically you will ask for?
Preductal and postductal saturation.
Where you will take for preductal oxygen?
Preductal will be right upper limb.
Right upper limb.
Postductal will be either of the
Lower limb. Okay. Why that is important? Preductal and postductal.
If it is duct dependent lesions, there will be a difference in preductal and postductal, which is more than 4.
So let's go to the fetal circulation. So when does the PDA usually closes?
After within 3 months.
Usually. When you say that, it is patent ectosis arteriosus,
Yes.
usually.
If
Imagine that for a newborn, you're taking an echocardiography. Like within 48 hours, you are doing an echocardiography. The PDA might not be closed, but usually within a time frame. Usually within 2 weeks time. Before that, the PDA usually will settle. So usually, unless and until it's a duct dependent lesion. So that is very important. Duct dependent lesion, non-duct dependent. If it is a normal physiology, slowly it will start closing down. So by this time, it will close. Usually it should be closed. So that is the important thing that we need to keep in your mind. Next question, preductal, postductal. So what are the differences? What if, for example, I am telling you preductal saturation is, upper limb saturation is 95 and lower limb saturation is 80.
if it is more than 4% difference is there, then it will be like preductal, duct dependent lesions will be there. It's lower
Okay.
limb saturation is less.
Yes. Reverse.
It will be any preductal, right-sided lesion.
Right-sided heart lesion. Okay.
Obstructive lesion.
So let me ask you another question. You said regarding SpO2, difference in the SpO2. What is the next thing that you wanted to know? Saturation you said, respiratory rate you said, then in the chest.
Any
Crepitation, no crepitations.
any murmurs.
Murmurs, I am unable to hear and differentiate anything. With the heart rate of 130, 140 for a newborn, I am unable to identify in a busy emergency room.
Any CRT.
CRT less than 2 seconds. Less than 2 seconds.
No.
Next thing.
Circulation.
Circulation, what you wanted to know?
BP, the hypotension.
Before BP,
Pulse rate.
Pulse rate. I told you 140. What else you want to know on the pulse? Whether upper limb and lower limb pulse. Again, coarctation of aorta. You have to keep that in your mind. So you have to see upper limb pulse and lower limb pulse. Whether the volume of pulse is same in the upper limb and lower limb. Next one, blood pressure difference. Ideally, it is difficult for a 20-day-old to. It is very easy technically to say, but it is difficult to do an upper limb and a lower limb blood pressure range. But you have to think that also. Upper limb and lower limb pressure difference also you need to consider.
Then disability.
Okay. Now I am giving a scenario. I am telling you this child is having an oxygen saturation of 80%. The same child, what we are discussing, the child is having 80% saturation, lying on the mother's lap, sleeping on the mother's lap. That will be the clear history. So what will you do now?
We will give oxygen. We'll just try for there is a hyperoxia test.
Okay, so one important thing what I wanted to tell you, unless and until the child is tachypneic, don't administer oxygen. So that is first dictum that you need to keep in your mind. The child is cyanosed and is in respiratory distress. Child is cyanosed and in respiratory distress, you can try with your hyperoxia test. You have to, what is hyperoxia test? Can you just brief me?
Hyperoxia test is we have to give 100% oxygen for 10 minutes. If it is neonate, we can give by a hood.
Okay.
And then we check for the change in saturation. It is the formal hyperoxia test is informal hyperoxia test is formal.
Informal only we are going. Formal is difficult. We will not be able to do. Arterial puncture for a child 20-day. Why you wanted to do? Unless and until it is really important. Want to do a co-oximetry, I will agree. But otherwise, we don't want to do an EPG. So informally, hyperoxia test is what we perform.
So if it is more than 10% change in saturation, then it is mostly will be the pulmonary cause for cyanosis.
Okay. So simple dictum what I will say. First rule for giving oxygen in a newborn. If the child is not tachypneic, regardless of the oxygen level, don't give oxygen. If the child is comfortable lying down without any issue, don't try to attempt giving oxygen. This child, I'll just do one important thing, masterly inactivity. That is the only thing I will do. Second thing, if you do a hyperoxia test, the same child, if the child was tachypneic, you think that probably it's a pulmonary reason. Like you think that it's a sepsis, pneumonia, a gram-positive septicemia, something you are suspecting. Specifically in 2-day, 3-day-old child, you have to definitely consider meconium aspiration and all those things. So simply you put 100% oxygen via hood. That's the only thing that is possible. And you wait for 5 to 10 minutes, not more than 10 minutes. Maybe 5 to 10 minutes is a reasonable time. See for saturation improvement. Previously it was 80. Now it has increased to 83, 84. That's it. Previously it was 80. Now it is like 95 and above. There is significant improvement. Then you can continue on oxygen. But otherwise, that leaves a clue that probably we are dealing with a pulmonary issue. So when you are giving oxygen, saturation is improving. The other one, whatever be the oxygen that you are going to give, the lesion, whatever is there, it is going to mix your blood. So the saturation is never going to increase. So you can confirm that probably we are dealing with probably a congenital cyanotic heart disease. So that is simple hyperoxia test. If the name implies, it's a very simple to give oxygen and see for the improvement. If there is no improvement, don't give oxygen, remove it. If there is, why we want to remove it, very important. What is the reason why we don't want to continue on oxygen?
Oxygen is a pulmonary vasodilator.
Yes, one.
So the ductus arteriosus may close.
And the child can suddenly deteriorate and can go into shock. So giving oxygen can be a double-edged weapon in this scenario. So cyanotic child, unless and until the child is tachypneic, irrespective of the level, don't give oxygen. That's the first rule that you can remember. If you want to give oxygen, try an hyperoxia, simple bedside test, and you take the call of giving oxygen or not. So that is related to oxygen. Now you have come to probably you are dealing with a congenital cyanotic heart disease. What ideally needed to be done? In emergency room, we need not do anything. The child needs a specialist consult. So that is the first. We don't have to intervene anything at that point of time. We want to do any blood test at this point of time? I don't want to do. Generally, it is not needed. Any blood test that's not going to help. The only thing what is required will be an even X-ray. If you have a good pediatric cardiology center, I will say directly go ahead and do an echo. Directly go ahead and do an echo. But for the sake of discussion purpose, let's see what are the investigations that we wanted to do. Blood investigations. If the child is tachypneic, definitely yes, we will be doing investigation. What are the investigations that you think that is relevant in this case?
Coximet, hemoglobin.
Okay, hemoglobinopathies you want to do, you can ask for a coximetry. Then you can do an CRP. We have to look for an infective pathology. Agreed that we can do then. The child is drowsy, hypotensive, maybe the GRBS we can do. So that is one investigation that again, which might be of helpful for this group of patients. So that is related to the blood test. That's it what we wanted to do. The next one, X-rays. X-rays, how? Because there are certain named X-rays that will be coming for your examination. So that is the only reason, because I hardly had done any X-ray to diagnose an tetralogy of Fallot or a transposition of greater arteries or any of these things. But there are some named signs, but that might come for any of the examination. For that purpose, we should know what are the X-ray findings that you might need to look in for a patient with congenital cyanotic heart disease.
Boot-shaped heart.
Okay.
Tetralogy of Fallot.
Boot-shaped heart and tetralogy of Fallot. Okay.
And snowman in TAPVC.
TAPVC.
And egg-on string on TGA.
On transposition of greater vessel. Blackout lungs. Completely blackout lungs. That is maybe you will be able to see right-sided lesions. Very rarely right-sided lesions, fully blacked out lungs, very high exposure, blackout lungs. So these are the 4 X-rays that you need to keep in your mind when you are considering a cyanotic heart disease. Boot-shaped heart, then egg-on string appearance, and the final one is the snowman appearance. Because these are all, name has got some fancy things. So when you write for the exam, you will get some mark, and maybe an X-ray will be placed for one of the entrance examination. That might be helpful. But usually, routinely, we are not doing X-rays. We might be doing X-ray looking for a pulmonary cause. For diagnosing a total anomalous pulmonary illness, none of them are doing an X-ray. Maybe in a peripheral setup, but maybe in our hospital, we are never doing that initially. Now, let's see. We haven't discussed one thing, depending upon the color of the child. I said cyanosis. So, what are the 3 color changes that you can anticipate for a child with probable cyanotic heart disease? One is the blue cyanotic child that we have discussed already. Gray, What are things that you need to keep in your mind? Pink, leave it, pink. Pink. It can be a part of pink and respiratory distress. It can be part of your cardiac failure. It can be part of your cardiac failure. Pink and gray, it can be mixed lesions. It can be seen in mixed because you can have different types of lesion. You can have mixed lesion. You can have a gray baby. So pink baby, gray baby, blue baby. Three things that you need to remember. So now we discussed regarding X-ray, blood investigation. Coming to ECG. ECG again. We can do an ECG, but for a 20-day-old baby, it's a little bit difficult to get done an ECG. By looking at the ECG, what are the key things that you can differentiate? What are the key things that you are going to look in an ECG of a newborn?
Any right ventricular hypertension.
Right ventricular, RVH. RVH is and
right axis deviation.
Right axis deviation. So these are the one important aspect that you need to look in for. The next important investigation that you want to do is an echocardiography, where you can almost confirm the diagnosis, whether it's a tetralogy of Fallot, whether it's a transfusion of greater, but you need expertise. You need have a good pediatric cardiologist to get these things done and get it diagnosed. So that is the next option for you. Now let's see what are the, once you diagnose, okay, what are the other key interventions that you need to do in an emergency. So suppose imagine that this child is brought, because many of the time the child can be sick and they will be brought in respiratory arrest, or they are going for an impending respiratory arrest. So you need to intubate these babies. So as an emergency physician, it is very important to know we should be avoiding the use of
Ketamine.
Ketamine should be avoided. Why ketamine should be avoided?
Sympathetic.
It can again
Increase the sympathetic tone.
increase the ketamine. Sympathetic activity and systemic vascular resistance against will increase, so that is not good. So it is not recommended to use ketamine in suspected cases. Ketamine is totally should be avoided. What is the drug of choice? Etomidate. First drug of choice is etomidate. Second one is fentanyl. If you don't have etomidate, you can go for fentanyl. So keep those things in your mind. Next important thing, suppose the child has been brought in shock. Cyanosis with shock. Very challenging situation. How the cyanosis can be due to, peripheral cyanosis can be due to the shock itself. So how will you tackle that?
If there is, we are suspecting any congenital heart diseases, in 5 to 10 ml per kg is around about 20 minutes, and then look for the signs of any fluid overload like in pulmonary edema.
What are the signs that you will look in for?
Basal Krebs we can then,
okay.
echo we can do,
then
IVs.
Hepatomegaly. Hepatomegaly is one important investigation, only important bedside thing that what we can do for, look for. And mother can sometimes that they are feeling something lump over the right lower abdomen also. So the right upper abdomen also. So that can be one presentation. That when we missed regarding the tachypnea and decreased feeding and all, no, maybe hepatomegaly also can be one of the presentation. So remember that you have to start with 5 to 10 ml per kg of fluid bolus. And you can resist it. If you are finding that primarily it's a cardiac failure, there is no hypotension, furosemide can be given. You can give furosemide. Then you have to think of adding on milrinone or enamrinone or any of these drugs depending upon the patient's condition. Then what else you have wanted to give? Prostaglandins. Where you will give prostaglandin nutrition?
It is a duct dependent lesion.
Okay. So in an ED, how will you able to identify probably it is a duct dependent lesion? What are the duct dependent lesions where prostaglandins can be given?
Contraindication is TAPVC obstruction.
That is the only one from all the cyanotic heart disease. Totally anomalous pulmonary venous circulation is where you can't give prostaglandin. But rest all condition, you can give prostaglandin, where other one it is contraindicated. So for a cyanotic child coming to the ED, it is very difficult for us to decide to give prostaglandin or not, unless we know that it's a duct dependent lesion. But giving prostaglandin can be a life-saving measure. So prostaglandin, total anomalous pulmonary venous is a rare thing, but you have to sometimes initiate on it. But if you don't have any other features, you need to initiate prostaglandin. So when you decide, okay, I have to start prostaglandin, you decided that it's a duct dependent lesion, and how will you start infusion?
If the duct lesion is very large, we can start on its low dose, that is 0.01 microgram per kg per minute.
Okay.
And if it is restrictive, we can start with 0.05 microgram per kg per minute, and the maximum dose is 0.1 microgram per kg per minute.
Okay. Okay. So prostaglandin. So these are the things that what we need to start off fluid bolus for hypotension, furosemide. Then the next important thing is the prostaglandin infusion. Okay, so that is your cyanotic heart disease. Okay, so anything else that you want to discuss?
If there is any apnea of the patient, we will usually do bag and mask. So contraindications for bag and mask ventilation. First is any tracheoesophageal fistula or any congenital diaphragmatic hernia, and then any lung hypoplasia is there. And then the adverse effects of prostaglandin infusion. Apnea is the main thing. So if you are planning to transport the baby on prostaglandin infusion, better to intubate and send the baby. And hypotension and vasodilatation can be there. And necrotizing enterocolitis is a not adverse effect, it is a long-term complication. And then if there is deterioration after starting, then it will be, most probably it will be TAPVC.
Okay, fine. Cyanotic spell, how the patient will be presenting?
During there will be crying episodes followed by unconsciousness and then cyanosis.
Okay.
Lasting for 1 to 2 minutes, and then they will spontaneously regain.
The child is brought in cyanotic spell, what you will do?
And it's back and must intubate, just observe the baby. And
any role for morphine? Any role for morphine? Any role for morphine? That's my question. Okay. So let that comes as a comment. Role of morphine in cyanotic spell. What all things that you want to do in case of a cyanotic spell. So cyanotic spell, again, it can even happen for an adult patient. Like what we had seen, suddenly the patient was having, the other patient we had a couple of weeks back. One lady, she was in the dissection hall. She suddenly felt she's having worsening of cyanosis, and she was brought into the emergency room. So that may be due to the cold environment or prolonged standing. So these are the usual trigger for an adult patient also. The adult patient is having a congenital cyanotic heart disease which is untreated. They also can present with the similar way. So cyanotic spell is very important. So previously, what are the changes? Let's see as the comment. Okay, fine. Anything else we have discussed? Okay, fine. Thank you.